में, तो होपफुली मैंने शरीफ हाशमानी साहब को भी रिक्वेस्ट की है, ही विल बी देयर विद हिज टॉक्स। वी आर वेलकम डॉक्टर शरीफ हाशमानी, माशाल्लाह ही इज़ देयर। अब हमें खैर है, चेयरमैन साहब आ गए हैं तो अब तो सेल्फ ऑथोराइज हो गए हैं हम। तो सईद इकबाल साहब आए हैं सर? सर सईद इकबाल साहब आए हुए हैं? चलें, अगर वो आ जाएंगे तो हम दोबारा नीचे आके बैठ जाएंगे। तिलावत करूं सर? जो आप कहेंगे चेयरमैन साहब, जो कहेंगे। तो जी सुरख चेयर पे चेयरमैन साहब बैठेंगे, द रेड वन। बैठें सर प्लीज। तो चेयरमैन साहब ने आते ही अपनी चेयरमैनी का इस्तेमाल किया है और मुझे हुक्म दिया कि पहली टॉक डॉक्टर शर्मीन की होगी। जी प्लीज अपनी टॉक रेडी करें आप, और हम तब तक तिलावत करते हैं। औज़ु बिल्लाहि मिनश शैतानिर रजीम, बिस्मिल्लाहिर रहमानिर रहीम। वल अस्रि इन्नल इंसाना लफी खुस्र इल्लल्लज़ीना आमनू व अमिलुस सालिहाति व तवासौ बिल हक़्क़ व तवासौ बिस सब्र। असर की कसम, इंसान नुकसान में है। असर क्या है? ज़माना। और ज़माना क्या है? माजी, हाल और मुस्तकबिल। ये सब मिलकर ज़ुबाना बनता है। गुजरे हुए, प्रेजेंट, आइंदा आने वाले सब ज़मानों की कसम अल्लाह रब्बुल इज़्ज़त की तो सब पे नज़र है। उन सब को गवाह बनाकर अल्लाह फरमा रहे हैं कि इंसान खसारे में है, सिवाय उनके जिन्होंने जो ईमान लाए, जिन्होंने नेक अमाल किए और जो हक बात की तलकीन और उसके रास्ते में आने वाली मुश्किलात पर सब्र करते रहे। तो अल्लाह रब्बुल इज़्ज़त हमें इसमें जो मुख्तसर तरीन अंदाज में इंसानी ज़िंदगी का मंशूर बयान किया गया है, अल्लाह हमें उसे मरने से पहले पहले समझने और उस पर अमल पैरा होने की तौफीक अता फरमाए। वमा अलैना इल्लल बलाग। तो अब आप तैयार हैं डॉक्टर शर्मीन? तो वी स्टार्ट द सेशन विद डॉक्टर शर्मीन टॉक। और उसका क्या टॉक क्या है? शर्मीन की आपकी किस टॉपिक पे है? इन्फॉर्म्ड कंसेंट, प्रोज एंड कॉन्स।
अस्सलाम वालेकुम प्रोफेसर मज़ा साहब एंड अस्सलाम वालेकुम प्रोफेसर हाशमानी। आप मेरे पास कोई शेर व शायरी नहीं है, सो आई एम जस्ट गोइंग टू स्टार्ट विद माय प्रेजेंटेशन। आई वुड लाइक टू नो, आप में से कोई लोग रिफ्रैक्टिव करते हैं? कैन यू रेज योर हैंड इफ एनी वन ऑफ यू डू? आप करते हैं सर? राइट। नहीं, उनके अलावा कौन करता है? दैट्स द इम्पॉर्टेंट थिंग टू नो। सो मेरा जो टॉपिक आज है वो थोड़ा सा डिफरेंट है। इट्स एडवांस सरफेस एबलेशन विद स्ट्रीम लाइट, प्रोज एंड कॉन्स ऑफ एन इन्फॉर्म्ड कंसेंट। मैंने ये प्रेजेंटेशन एक की थी जिसके अंदर मैंने स्ट्रीम लाइट को इंट्रोड्यूस किया था। कराची में कैरोप्थ में हुई थी। सो दोज ऑफ यू हु वर देयर वुड हैव हर्ड दिस प्रेजेंटेशन, जिसके अंदर स्ट्रीम लाइट को कैसे किया जाता है वो सारी चीज़ें बताई गई थी। अभी मैं थोड़ा सा पहले जो हाईलाइट करूँगी, लेट मी टॉक अबाउट व्हाट इट इज़ एक्चुअली। सो दिस इज़ माय डिक्लेरेशन स्लाइड। नो, PRK या फोटो रिफ्रैक्टिव कैरेटेक्टमी, वी ऑल नो इट हैज़ बीन देयर फॉर एजेस एंड इट्स अ टाइम टेस्टेड safe procedure which is done when chosen to do. Conventional PRK की अपनी problems थी which included, मेरा echo बहुत ज़्यादा हो रहा है। Conventional PRK की अपनी problems थी जिसके अंदर problem epithelial re-epithelialization की थी। Haze की was one of the most important problems faced in PRK। फिर जिसमें conventional में जिसमें alcohol use किया जाता है वो stem cell toxicity का issue था। Then there were other things which included पेन पोस्ट ऑपरेटिव एंड ऑल्सो द इम्पॉर्टेंट थिंग कि क्या इन पेशेंट्स की जो विजुअल एक्यूटी है वो कितना टाइम लेती है टू कम टू द एक्चुअल एक्सेप्टेड रिजल्ट्स। सो लुकिंग एट ऑल दीज थिंग्स, द डिफरेंट कंपनीज मेड डिफरेंट थिंग्स। और फिर ट्रांस PRK इंट्रोड्यूस हुआ जिसके अंदर 2 स्टेप इनिशियली स्टार्ट हुआ, जिसके अंदर बिकॉज आई यूज़ द एल्कॉन प्लेटफॉर्म, सो देयरफॉर आई एम मोर फेमिलियर विद दैट प्लेटफॉर्म। With other platforms, other forms of surface ablation were also introduced. So, uske andar to counteract the severity of corneal haze, to counteract कि reepithelialization जल्दी हो, pain कम हो, visual acuity जल्दी recover हो. For all those things, then trans-PRK came in which a two-step platform was used. The PTK platform, those who do refractive surgery are aware of कि PTK platform भी कुछ होता है, तो उसको use किया जाता था to remove the epithelium. Then a second platform was the PRK platform जिसमें ablation की जाती थी. The problem faced over here was that there had to be a minor correction which needed to be done when epithelium was being removed. और जो आपका post-operative result था उसके अंदर कभी-कभी what was there could be surprises, refractive surprises. So in order to overcome that, then came the single-step PRK. अब single-step PRK ये एक और slide है जो मैंने बहुत पहले last year लाहौर में यहाँ पे की थी when I was doing the PTK PRK. Then I now moved to single step PRK. So single step PRK के अंदर what is happening is that there is a card which is called the streamlight card जिनके पास Alcon के excimer laser है उसके अंदर ये card लगाया जाता है, and then we have a single platform which is going to remove the epithelium and also ablate the tissue. Okay, so it is like PRK, it's just कि conventional तरीके से हम epithelium अब remove नहीं कर रहे, we are just removing it in one go. So the difficulty which was faced when doing a two-step trans-PRK was addressed, and a wide range of refractive errors could be corrected. The difference in our particular in the excimer laser by Alcon is that when we are doing the procedure, during that procedure जब आप PRK का regular procedure कर रहे होते हैं, then there is an arrow. So if you see that yellow arrow, let me see if I can use my pointer. So when you come across this yellow arrow, then you have to remove your foot from the foot pedal, and you have to stop the laser for 10 seconds. There is no automatic stop. So the surgeon has to be aware that when they come across this arrow, they have to stop for 10 seconds and then restart the laser again. So they can put their foot back on their pedal and the laser starts again. So it's a very simple, easy procedure to do. Now, why when we have LASIK, which is one of the favorite procedures, Dr. Hashmani ka to favorite tareen procedures hai. I think he doesn't like PRK at all. So why would you want to switch to PRK on a patient who has come to you for LASIK? Okay? And the other important thing is that how will you convince your patient that this is something that is a good procedure for you without having any kind of personal bias in that? Okay? So at our center, we do what is called an informed consent, and I'm going to talk about the informed consent in a minute. It's like any regular PRK procedure or any LASIK procedure. When the eye is anesthetized with the topical drops, the speculum is put in, the patient is asked to look at the blinking green lights, and the laser which has been pre-programmed is then started. When you reach the arrow, then you stop, restart again after 10 seconds, and after doing that, MMC is applied. After applying the MMC, you wash with the chilled BSS. So the difference is the chilled BSS also is what we are using in this. Usually, we put the BSS solution bottles in the fridge at least 1 to 2 hours prior to the procedure. Then the bandage contact lens is applied like in any PRK procedure, and topical steroids and antibiotics given. Now, reason for selection. You see, this is the most important thing. A lot of time patients come to us and they want to undergo the LASIK procedure. It is an expensive procedure. At different places, it has different prices, and the market is pretty competitive. Sometimes you're not able to, meet those prices. Then you have to give the patient an option in which you will get as good a result as the LASIK procedure with a lesser cost. So streamlined PRK is one of those procedures. And we had patients who had wanted to go LASIK procedure, and when we explained it to them, then we were willing to undergo cost, because of the cost, they were willing to undergo the streamlined PRK procedure. So when I talk about informed consent, it's a shared consent. So you are sharing each and everything that there is to be shared, all the technical things which need to be shared with the patient. You listen to the patient's view, and then there's a mutual decision that you come at. So then there are some patients who would still not go for this procedure and would prefer to undergo a LASIK procedure. A patient who is extremely anxious. Now when patients, especially refractive patients, most of them are very anxious. They are high personalities, type A personalities, and they get very anxious and they want to know how long the procedure is going to take place. Will they be able to focus? During docking, will they close their eyes? So this is another category of patient. When you are talking with your patient and when you're talking about the procedure, and its pros and cons, then this is one of the important things, because patients who are extremely anxious might find it very difficult, especially during the docking stage of those who are doing femtosecond LASIK would understand, or the microkeratome, that when the flap is being created, that's the most critical stage, and sometimes the patient who is a very anxious patient might not be able to keep their eyes open, or may get disturbed by the blackout phase that they have, or the pressure that they feel. So that's another very, very important consideration. Now I've written a terminology, suspicious topo. So I'm not talking about a topography which is indicating that this is keratoconus. If sometime back, few years back actually, one of the person who mastered corneal topography, his name was Sanjab, he had written, he had very nicely categorized into mild and moderate risks and high risks. So when we are talking about a mild risk, then I'm talking about, like when I look at a corneal topography, even a risk like if the K readings are not very normal, but the rest of the parameters are okay, I still want to be very careful when doing LASIK procedure, especially if the residual bed is not going to be like 400 or something like that. Though the cutoff point is between 250 to 300 microns. So in these patients, or if I see a posterior float, so in these patients, in this case, the parameters are normal, but one or two parameters, or if you're following in the yellow borderline, then this is preferably, if you are going to do a procedure, then this is a better procedure. We spoke about, if you are thinking that there's going to be less residual bed, then this is a good procedure, because obviously you're not making a flap. Patients who are going to be in combat sports, especially in army and other things, then this is a good procedure again, because of no LASIK formation, flap formation. Eye squeezer, deep sockets, all these things needs to be looked when you're doing a procedure, and these patients become safer when you're doing streamlined PRK. So the three essential steps of the shared decision making is, we recognize this thing that, look, there are different procedures and we need to talk to the patient about them. They have to come to a mutual understanding, and we having our best knowledge, evidence-based knowledge, then we are able to share with the patient. And this leads to a very, very safe approach. The other important things for the patients to know is that there is no instrument contact. Patient will have a very good intraoperative experience, and the surgical time is extremely short. It's about 5, 10, 20 seconds, depending upon how much the refractive error is. And there is no toxicity with alcohol to limbal stem cells. As I spoke about cost, which is a very, very important thing. The limitations are, if the patients are very aware of it. They go in the market, they come back, they say, are you going to do a Contora vision with this this kind of a PRK procedure? So no, Contora is not possible. If you're thinking of adding a CXL to your LASIK procedure, then CXL is not possible with streamlined procedures. And though recovery is slower, the results are the same, and BCL needs to be removed. So this is just one small video I wanted to show how the procedure is done, and then we are done. Okay, thank you.
ज़फ़र साहब, ये है ना, ज़फ़रुल इस्लाम साहब तशरीफ़ फरमा हैं. तो प्रोफेसर ज़फ़रुल इस्लाम साहब is invited to deliver his talk on ICL, fake IULs, pearls.
सर ये बस खत्म हो रही है, 2 सेकंड में खत्म हो रही है.
अभी खत्म नहीं हुई. हम ही सो गए दास्तां सुनते सुनते.
Treatment zone size and location is automatically determined by the laser based on the PRK ablation profile, and the laser's multi-dimensional eye tracker is active
यार आवाज ही निकाल दो.
PTK and PRK procedure. Streamlined, a streamlined one-step procedure combining PTK and PRK, is available for wavefront optimized profiles.
Thank you so much. No problem at all. Thank you. Thank you for taking me first. Thank you, sir. Allah ka shukar, aap kaise hain? Theek thaak. Yeah, same here.
Good afternoon, everybody. Thank you, Mazari and Hashmani. My talk is on phakic IOL, pearls, and the parallels. I dedicate this lecture to my very dear friend, late Nakash Sadiq. Actually, we together introduced this new technology to Pakistan in 2010 after taking together a course in China. And I wish him all the best and may God bless him highest abode in Jannah. It has been declared most amazing invention by the Time magazine in 2004. There are mostly now two type of phakic IOL practice. One is the PC one. PC IOL is called ICL, and the other one is iris fixated IOL. It's Artisan, Artiflex. Its name is Varices or Veriflex. In USA, is the same thing. Indications are high refractive error where laser is not possible, stable or stabilized keratoconus, pulse laser ectasia, patient not willing surgery on cornea. There are many patients, especially in the West. Defective epithelial regeneration, healing problem, etc., etc. And then dry eye. Okay, so talking about the pearls, is composed of a very high advanced material, collamer. Collamer is composed of collagen and hydroxyethyl methacrylate. The quality of collagen is that it combined with fibronectin, which is found in the body, and form a layer around the lens. So the beauty of that is that it's not recognized as a foreign body. There is no precipitates deposited on the lens, no pigmentation on the lens, and lens is clear. And that's very amazing. Then other pearl is its design. It has a plate haptics with 4 attachments, so there's less chances of centration, especially if you're using toric lens. And then it has got anterior convexity, so there's a distance between the crystalline lens and the ICL, and that distance ideal is 4 to 500 micron. And how it is determined, I am coming to that in the parallels. And then again in the design there are 2 holes, 2 holes on the each side of the optic, and then there is 1 hole in the center which doesn't affect the vision. But these holes allow a normal flow of the aqueous behind the lens, so there are less chances of the cataract formation and less chances of the pupillary block glaucoma. So this central hole has actually revolutionized this lens. Another pearls which have been in published studies that it is highly safe, effective and predictable lens. And I mean, it's surprising that patient satisfaction rate is 97%, and that's also my experience. And there's minimal pre-op and post-op complications. The parallels are this expensive lens, but one thing, the good is that it's reversible. The rest of the procedures are irreversible. It's a bit expensive workup. You have to do like white to white. You have to measure CCT, axial length, and all this information you have to send to the company. They put it on the nomogram, and then that will determine the power of the lens and the size of the lens. And here, the other parallel is a bit steep. There are 2 steep learning curves. One is the loading of the ICL in the cartridge, because lens is very thin in the center. So you just can't touch it, any metallic part. So you have to use this foam tip plunger. You take it out, and then you put it in the cartridge. So you can always ask the provider to arrange wet lab for you. Sitting here, I think Khalid, he can arrange the wet lab for you. You can do it 5 to 10 times before proceeding with it. And then you pull this with this forceps is supplied by the provider, and then you pull the lens by holding it firmly to the haptic till the edge of the optic, so it should not rupture, and bring it into the tip. Now the other problem is the insertion, because it should not, when you are inserting, it should not open upside down. So you insert through 3.2 millimeter incision with self-sealing, and with the tapping movement you are slowly, very slowly with the tapping movement, you insert it when it's go about 60% is inside the anterior chamber. You wait for it to open. There is a marker on the right side of the haptic. You would look at the marker. If it's not proper, you can always rotate your injector and it should open properly. Once it's open in the AC, you can always tuck the haptics back into the PC with the spatial manipulator provided again by the providers. I will quickly go through it. I have done about 51, it's very expensive. I have only done 51 eyes in 30 patients. You can see all these details. They included stabilized 8 eyes of keratoconus and 4 eyes of PRK. There are no para complications. All patients were happy. And that's very good. And about 50% of patients got better vision than the spectacles. And the reason is very, very clear, because magnification effect is no more there. And one patient developed TAS next day. There were 2 corneal edema, high vault in one patient, which was 1000. Luckily, it reduced to 700 macron over 3 years. And there was no glaucoma or pigment dispersion or like things in this patient. Then there was steroid-induced glaucoma in one patient, which recovered after stoppage of steroids. There is peripheral lens opacity in one patient. Still, its patient is okay. It's not yet come to the center. And in one patient, ICL is almost touching the cornea, but there is no changes in the lens. And over the last 12 years, I have yet to do any explantation. So in conclusion, I would say ICL phakic lens surgery is an effective, safe and predictable procedure. Extensive and methodical pre-op workup and correct measurements are important to get better results. And it's a tricky eye surgery, so follow rigorously the guidelines. That is very, very important. You write it down. It's better that you do it first to few cases under supervision. That's much better. And you write it down what you have to do, because this is only 8 minutes talk, so I can't talk anymore. I think I have taken 8 minutes. I have to do the justice, so thank you very much.
Thank you very much, Professor Zafrul Islam, for enlightening us about phakic IOLs, and we welcome and invite humbly and happily Dr. Sharif Hashmani with his sir, वो लैनी नहीं दिंदा, उन्हें टाइमर लगा हुआ है. You are lucky. Oh, we know how to mix the art and science. तो शरीफ हाशमानी साहब के 2 टॉक्स हैं. एक तो इसी टोरिक IOL है, द पर्ल्स, और दूसरा है माय एक्सपीरियंस ऑफ आर्टिफ्लेक्स वर्सेस ICL इम्प्लांटेशन. So we are lucky to have 2 iconic figures, one by one, consecutively, and they are enlightening us about ICL and phakic IOLs and toric IOLs. So, Dr. Hashmani, are you ready, sir?
Yes, sir. Yes, sir, and no, sir, both. Bismillahirrahmanirrahim and Assalamu alaikum. Actually, there was a misunderstanding from my side. Yeah, I thought my paper is tomorrow, so I didn't prepare it. I was about to prepare it at night, but I was informed that it is today only. So, very good, no problem. And I won't go into the details of Dr. Zafrul Islam has nicely covered up everything. I have got the experience of both the lenses, Artiflex and Artiflex and ICL, and I especially invited Dr. Khalid, the distributor and ophthalmologist, to this show so that I can ask him, okay, how can we improve the results of ICL. Thank you very much, Dr. Khalid, for being here. I won't go into the details. LASIK is the gold standard, but we cannot offer LASIK to every patient because of its own complications. And if the number is very high, or if the cornea is flat or cornea is too thin, then we have no option but to go for ICL or phakic IOLs. So these lenses, they offer a very promising alternative because they preserve accommodation and they are reversible and they maintain the original prolate shape of the cornea. So जब patient से हम ये कहते हैं कि इसको हम निकाल भी सकते हैं तो ताकि आप दोबारा I am doing these phakic lenses Artiflex since 2007. That is about 17 years now, and I have not removed any lens because of uncomfortableness to the patient. Because of cataract, yes. Because of any other reason, yes. But 2017 till today, I have not found any problem. Any problem means that the endothelial cell loss or bullous keratopathy I have not found in my own cases, and these all patients are regularly under my surveillance. And as you all know that these Artiflex and Artisan lenses are available up to minus 23.5 in Artisan, that is non-foldable, and Artiflex up to minus 26, and ICL is available in up to minus 20 up to 4 cylinder. And this is how it appears, Artiflex lens. It is hooked onto the iris. I can't mark it here. That's it. You can see here that it is nicely tucked on the iris, and you can see a beautiful iridectomy up. And you have to take a special care to the endothelium by putting high viscous viscoelastic. So we have done many cases in hundreds, and I don't want to go into the details. One of the patient did get a traumatic dislocation, and we reported that case, and then it was re-enclaved. So we directly go to the Artiflex surgery. You've seen that we have made these two markers here, and these markers are a bit, this is the first pearl, कि आप ये थोड़ा सा दूर रखें उसको, लिम्बस के ऊपर नहीं रखें, वरना ये होता है कि जब आप टक करने लगते हैं तो आपको नज़र ही नहीं आता because of this mark. So इसको थोड़ा सा दूर रखें. This is the first pearl of implanting the lens in. और इसके बाद आप मायोकॉल डालते हैं. मायोकॉल इसलिए कि प्यूपिल कॉन्स्ट्रिक्ट हो जाए. फिर आप ये जो इंसिशंस आपने दिए हैं उसको भी आप देखते हैं कि दे आर वर्किंग नाइसली. ये इंसिशंस हम पहले 3 बना लेते हैं, फिर ये इम्प्लांट कर रहे हैं. देखें आप, इन्हें इम्प्लांट किया एंड देन वी, अच्छा, दी सेंटरिंग, दी परफेक्शन जो है सेंटरिंग में अचीव करना ही आइडियल ये इसकी वो स्किल है. और ये आपने देखा, ये हमने सेंटरिंग किया एंड देन वी अगेन पुट द लेंस इन. जो मार्किंग जो की हुई है, ये मार्किंग हमें हेल्प करती है कि आपको किस जगह पर इसको टक करना है. और ये मार्किंग हम करते हैं कैंथस के साइड्स पर, कैंथस के उस पर. यहाँ भी आपने देखा ये हो गया और लेफ्ट पर. एंड वंस इट इज टक्ड. अच्छा, यहाँ पर जो आर्ट है वो ये है कि इसमें जो आप यूज़ करेंगे विस्कोइलास्टिक, दैट शुड नॉट बी द मिथाइल सेलुलोज, अदरवाइज ये आप टच करेंगे उसको. तो एक ज़माने में आती थी इनकी हीलोन 5, फिर इसके बाद डिस्कोविस्क आने लगी. लेकिन अब डिस्कोविस्क वगैरह नहीं अवेलेबल, तो हम लोग यूज़ करते हैं आपकी प्रोविस्क या डिस्कोविस्क, ये विस्कोट, क्योंकि कोई अवेलेबल ही नहीं है. और इसके बाद आपने पूरा ये निकालना है. दिस इज़ हाउ. और ये आपने हाइड्रेशन किया एंड योर ऑपरेशन इज ओवर. नंबर 1. दिस इज़ हाउ इट अपीयर्स पोस्ट ऑपरेटिवली. ये ICL आप नज़र आ रहा है आपको, वेल ICL जो प्लेसमेंट, और हम इसकी बहस में नहीं जाएंगे. कैटरेक्ट फॉर्मेशन, ये दी ICL जब डालेंगे तो ICL का जो आर्ट है ICL में the vault should be between 200 to 750 माइक्रोन। ये हमारा अपना केस है और हमने ये दूसरे दिन फिर एक हफ्ते के बाद इसकी OCT करके देखा है, तो यू कैन सी दिस इज आइडियली प्लेस्ड। सो दिस इज व्हाट वी हैव टू अचीव। अच्छा, ये अचीव करने के लिए साइजिंग इज़ मोस्ट इम्पोर्टेंट, और साइजिंग के लिए वी हैव टू डिपेंड अपॉन द सप्लायर कि आप उसको अगर करेक्ट डेटा दें। जो हमें कल बात हो रही थी डॉक्टर साहब से, वो यही करें कि आप डेटा करेक्ट नहीं भेजते इसलिए हमें प्रॉब्लम्स होती हैं। तो अगर करेक्ट डेटा दें तो लेकिन अगर UBM, मैंने इनसे रिक्वेस्ट की है कि UBM माइक्रोस्कोप वाला सिलसिला है वो शुरू करें, ताकि सल्कस टू सल्कस, ये आप जो डिपेंड करते हैं, ये जो मार्किंग, ये जो हम साइजिंग करते हैं, दैट वी आर साइजिंग ऑन द बेसिस ऑफ वाइट टू वाइट मेजरमेंट। और अब जो आ रहा है कि सल्कस टू सल्कस, तो अब ये एक स्टडी है कि सल्कस टू सल्कस, अगर वाइट टू वाइट और सल्कस टू सल्कस में फ़र्क है, अगर सल्कस टू सल्कस इज़ बिगर देन वाइट टू वाइट, तो आप जो साइज़ ये सप्लाई करें उसे एक साइज़ बड़ा ले लें, और अगर सल्कस टू सल्कस छोटा है तो एक साइज़ छोटा लें। इसके बाद 99% ऑफ द केसेस में जो स्टडी जो आई है कि उसमें कोई फ़र्क नहीं आया। हमारे अपने केसेस में हमने कुछ केसेस में देखा है कि आपकी जो वॉल्ट है बहुत ज़्यादा है, और कुछ केसेस में, एक आध केस में आपका वॉल्ट बहुत ही कम है, लेस देन 250, एंड दिस लेस वॉल्ट लीड्स टू द एंटीरियर सबकैप्सुलर कैटरैक्ट। तो पर नंबर अब मैं दिखाता हूँ आपको। The ideal vault size is from 250 to 750. Less than 1.25 can cause undersized ICL. Oversized ICL can cause glaucoma. So less sized ICL will lead to anterior subcapsular cataract. The oversized ICL will lead to glaucoma. ये आपका जो प्रॉब्लम है एंटीरियर सबकैप्सुलर कैटरैक्ट बना हुआ है इसमें, ये हमारा अपना केस है, और इसके ऊपर मैंने डॉक्टर खालिद से शिकायत की थी कि हम नई लेंस डालेंगे। फिर आई स्टार्टेड डूइंग द फेकिंग द आर्टिफ्लेक्स लेंसेज सिंस 2007। ये मैंने स्टार्ट किया 2018-19 आई थिंक, और इसके बाद फिर जब कुछ दिन ये हम करते थे, 2-4-6 महीने फिर छोड़ देते थे, फिर हम रिवर्ट बैक टू आर्टिफ्लेक्स, फिर हम इस पर आते थे। और जब ये रिजल्ट, ये जब प्रॉब्लम्स आते थे आपके एंटीरियर सबकैप्सुलर कैटरैक्ट के, और लेकिन असल जो चीज़ है वो ये है कि पेशेंट आर हैप्पी विद एंटीरियर सबकैप्सुलर कैटरैक्ट, दे आर नॉट कंप्लेनिंग ऑफ एनीथिंग। लेकिन जब मेरे पास आते हैं और आप स्लिट लैम्प पर देखते हैं तो यू आर नॉट हैप्पी, यार इनको तो सबकैप्सुलर कैटरैक्ट बना हुआ है, बट पेशेंट आर नॉट कंप्लेनिंग। सो बिकॉज ऑफ दिस हमने कोई लेंस आज तक नहीं निकाला। खालिद, ये आपके लिए सबसे अच्छी खुशी की बात। अच्छा, अब आते हैं हाउ टू इम्प्लांट, जो मैं आपसे बात कर रहा था कि यस सर्जरी। ये दिस इज हाउ यू, द मोस्ट इम्पॉर्टेंट पार्ट, इसमें दो ही चीज़ें हैं, लोडिंग एंड अनलोडिंग। यू मस्ट नो हाउ टू लोड द लेंस। ये देखिए आप, ये मैं लोड कर रहा हूँ, ये यूट्यूब पर भी है तो आप उसको भी देख सकते हैं। और लोडिंग जो है इसमें आपने ये देखना है कि ये आप उसकी कान पकड़ के, मैं कहता हूँ खींच रहे हैं हम, तो ये इस तरह से आपको लेंस को टिप पर ले आना है, फिर आपने अपना काम शुरू करना है। और जो खालिद कल जो बात कर रहे थे हम, वो ये कर रहे थे कि आप अपने स्टाफ को ये ट्रेनिंग दें। जो प्रॉब्लम हो रहा था एंटीरियर सबकैप्सुलर कैटरैक्ट का, वो अब नहीं हो रहा since last 3 to 4 months, and I am doing it every week. I am putting 2 or 3 lenses, और मुझे कोई प्रॉब्लम अब नहीं हो रही। The reason is कि I have changed the methyl cellulose. The recommended is methyl cellulose and not any other gel. लेकिन methyl cellulose भी बिल्कुल clear methyl, मैं पहले से methyl cellulose ही डाल रहा हूँ, लेकिन अब मैंने methyl cellulose चेंज की है। तो आप देखिए, ये जब once the lens is in, आप इसको टक करके उसके आइरिस के नीचे डाल दें। मसला ये है कि जब आप ये मिथाइल सेलुलोज की जो एम्फेसिस में इसलिए कर रहा हूँ कि मिथाइल सेलुलोज जब आप रिमूव करते हैं तो क्योंकि इनमें क्रिस्टल्स होते हैं जो हमारी पाकिस्तानी बनी हुई और जो 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 बनती आती हैं जो हम कैटरेक्ट सर्जरी में यूज़ करते हैं, उसमें क्योंकि वो क्रिस्टल्स होते हैं तो दे आर नॉट रिमूव्ड, ये जो आप वॉश करते हैं उसमें, तो दे आर ट्रैप्ड बिटवीन द लेंस एंड द क्रिस्टलाइन लेंस, और ये जो ट्रैप बिटवीन लेंस एंड प्रेशर इफेक्ट की वजह से कैटरेक्ट बनता है। तो दैट इज़ द रीज़न ऑफ कैटरेक्ट। तो ये आप लोगों को चाहिए कि आप पब्लिक को ट्रेन करें कि दिस इज़ द प्रॉब्लम, तो उसको आपने ठीक करना है। अगर ये ठीक कर देंगे तो आपका कोई प्रॉब्लम नहीं होगा। नंबर 1 लोडिंग एंड अनलोडिंग, ये इनको सिखानी है। नंबर 3 बबल्स नहीं आने चाहिए। जितने आप जब भी लेंस को लोड करते हैं और आप करते हैं इससे बबल्स आते हैं, दे दोज बबल्स वर्क एज, जैसे नज़र आता है होल है, जब हम लेंस से डाल रहे हैं तो वो हमें प्रॉब्लम कर रहा है कि एक होल और नज़र आ रहा है, तो वो कन्फ्यूजन में ही रहते हैं कि ये राइट साइड पर है या लेफ्ट साइड पर है। तो इसके लिए होल नहीं बबल्स नहीं आने चाहिए। तो ये पर्ल्स हैं जो जो आपको सीखना है, हमें सीखना है कि वाइल लोडिंग देयर शुड बी नो बबल, एंड जब आप अनलोड कर रहे हैं तब भी कोई बबल नहीं आना चाहिए। उसके लिए थोड़ा सा आपको मैं, हालांकि जितने भी अच्छे वाले मिथाइल सेलुलोज आर अवेलेबल इन द मार्केट, बल्कि आप कोई भी विस्को इलास्टिक ले लें, जब भी आप वो करते हैं बबल पहले निकलता है, बाद में जेल निकलती है। तो आपने पहले से बबल को निकाल देना है, ये अपने दिमाग में रखना है। नंबर 1। नंबर 2 कि आपकी साइजिंग जो आपको मैंने बताया। नंबर 3 कि दिस इज़ अ वेरी सोफिस्टिकेटेड सर्जरी, यू शुड टेक योर टाइम। ये नहीं है कि आपने फ़ौरन कि मैंने ये कैटरेक्ट सर्जरी की फ़ौरन, जब तक के लेंस आपने अंदर डाला और लेंस लीव नहीं कर देता अपनी जगह से, उस वक्त तक आप उसको वो नहीं करेंगे। तो ये हैं कुछ पर्ल्स, और ये मैंने सर्जरी आपको दिखा दी। आई डोंट थिंक कि इसके बाद कोई चीज़ रह जाती है। बस ये है। देन थैंक यू वेरी मच। कोई सवाल है तो बताइए आप। और ये बायोप्टिक्स का एक प्रोसीजर उन्होंने किया। बायोप्टिक्स मीन कि यू आर डूइंग सर्जरी, रिफ्रैक्टिव सर्जरी एट 2 लेवल्स, कि आपने आई लेंस डाला है, इसके ऊपर आप दिस यू आर डूइंग लेसिक ऑल्सो। सो दिस इज़ ये जो लेंस आपको नज़र आ रहा है, दैट इज़ अ कैशे लेंस, दैट वाज एन एंटीरियर चैम्बर लेंस इंट्रोड्यूस्ड बाय एल्कॉन ईयर्स बैक। और फिर इसके बाद हमने ये लेंस डाला हुआ है जो आप दिख रहा है, इसके बाद ऊपर आपने लेज़र किया, और लेज़र करने के बाद अब ये हम ICL में भी हमने 1-2 केसेस किए हैं जो हमने अपग्रेड नहीं किया अपने ये प्रेजेंटेशन को, तो उसमें भी हमने ये देखा है कि ये तो बायोप्टिक्स भी आप आराम से कर सकते हैं। सो दिस इज़ अ वेरी गुड सर्जरी एंड वन शुड डू दिस सर्जरी इन एवरी केस। थैंक यू वेरी मच। कोई सवाल है तो बताएं। अच्छा, ये विद ईयर्स ऑफ माई एक्सपीरियंस, ये सब कुछ करने के बाद last 6 months से I am putting ICL only, and I think ICL is far better than, not far better than, is as good as phakic lens. लेकिन phakic lens में प्रॉब्लम सिर्फ एक ही, मैंने कहा 2007 से मैं कर रहा हूँ, and hundreds of patients मैंने किए हैं, and they all are under my I repeat it, they all are under my surveillance, and every 6 months or year they come to me, and हम endothelial cell count सबका करते हैं। तो we have got no problem with them, but the only problem implanting के वक्त आपका जो स्टकिंग करते हैं आयरिस की, तो सेंटरिंग करने में बहुत प्रॉब्लम होती है। दैट सेंटरिंग इज अ हैसल। और आपका ये जो ICL है, अगर आप जो मैंने कहा, बबल अगर नहीं आता, विस्को इलास्टिक अपना चेंज कर दें मिथाइल सेलुलोज, तो दिस इज़ द बेस्ट लेंस। और थोड़ा सा ये सपोर्ट कर दें हमें, मैं फिर ऑन द पोडियम कह रहा हूँ कि आप अगर हमें UBM में अगर सपोर्ट कर दें तो इनके रिजल्ट्स 100% बेहतर हो जाएंगे। तो एंटीरियर सब कैप्सुलर कैटरेक्ट का प्रॉब्लम है, लेकिन यस, दिस इज़ द बेस्ट लेंस। मेरे पास नहीं है, लेकिन मैं यही तो कह रहा हूँ कि खालिद साहब हमें डोनेट करें ना यार। हाँ,
Because of the high refractive error, the flap was thin, 100 micron. So this is a problem. I deferred the surgery, and after 6 weeks, I have done changing the parameters, keeping my PTA less than 40. The patient was being again refractive surgery uski hui, and she attained 6.6 VN, very perfect VN. Another case, eccentric flap. As we all know, these are young myopic patients, very strong palpebrae superioris, strong orbicularis oculi. They, in spite of placing a speculum, they have got a severe resistance toward opening of the eye. Secondly, they are anxious. They are even the local anesthesia drops was inadequately put in this case. So you can very well imagine that here, this is temporal side, this is nasal side. The ablation is mostly, here it is large area of present between the limbus and the flap. Here it is almost touching up to the limbus. This also happens in these young patients because of, you can see patient is always moving. Kabhi aankh upar ja rahi hai, kabhi niche ja rahi hai. She is anxious, apprehended. Although procedure was fully explained, but she has this problem. How will you rectify this situation? I have very beautifully dissection बड़ी अच्छी हो गई, flap easily lift हो गया. फिर आपने क्या करना है? This is a photo disruptive procedure है. फिर आपने photo ablative procedure जो करना है, excimer laser जो करनी है, उसमें आपने ख्याल रखना है. Ablation zone आप छोटा रखें और आप अपनी depth को attain करते हुए, centration का ख्याल रखते हुए, trackers on कर लें. You will achieve the good VN. In this case, we also achieved 6.6 VN. Next case, difficult dissection and intra or stromal bleeding. This we commonly come across because of the previous experience in the other eye. This is second eye. I use this, you can very well see, this is 15-degree blade. I am dissecting the plane for my negotiation with the blunt spatula. आपने मार्क जो आपके पास अवेलेबल है, आप अपना प्लेन बनाएं. राइट हैंड के साथ प्लेन पहले राइट साइड पे बनाया, उसको नीचे ले सुपीरियरली जहाँ तक आपका हिंज है वहाँ तक लेके जाएं. देन स्टार्ट इट ऑन द अदर साइड. नाउ बाय यूज ऑफ द ब्लंट स्पैचुला I am negotiating the bed, and this patient was using contact lenses for the last odd 8 years. So there is intraoperative bleeding start हो गई हुई है पहले से. So just within a few minutes I am stopping. जब आपने blunt spatula कर लिया तो यहाँ पे आपने corneal epithelial tear या raised edges नहीं बनाने हैं. You again ask for a 15-degree blade, or by this just coming. शेकिंग हैंड टेक्निक, एक तरफ से आप 15 डिग्री ब्लेड लेके आए, दूसरी तरफ से आप स्पैचुला को एंड के साथ मिलाएं. जस्ट मेक अ स्मॉल नेक. नाउ ट्रैक बन गया, अब आप इजीली उसको नीचे तक निगोशिएट करते हुए नीचे तक ले जाएं. यू विल हैव अ क्लियर मार्जिन, आपका क्लियर मार्जिन का जो है वो फ्लैप बनेगा. नीचे देखें तो देयर इज लॉट ऑफ इंट्राऑपरेटिव ब्लीडिंग हुई है. यहाँ भी बेड जो है वो एडहेरेंटली अटैच्ड है. सो इस चीज़ को एडहेरेंस को ख़त्म करने के लिए आई आस्क्ड फॉर वेना सीजर. बजाय ये कि आप जोर लगाएं, रेज्ड एजेस करें, कॉर्नियल टीयर करें. जस्ट अ स्मॉल निक एट द इंफीरियर 6 o'clock, वेरी डेलिकेट कट हैज़ मेड अ वेरी ब्यूटिफुल फ्लैप एंड सर्जरी वाज बीइंग फिनिश्ड. और इंट्राऑपरेटिव जो ब्लीडिंग है उसको आपने थॉरोली वॉश करना है और वेजो कंस्ट्रिक्टर ड्रॉप्स इस्तेमाल करें सो दैट ब्लीडिंग रुक जाए, या स्पॉन्ज के ज़रिए से वहाँ पे उसको फोर्स अप्लाई करें. माई लास्ट केस इज डिफिकल्ट डॉकिंग. डिफिकल्ट डॉकिंग की कॉमन जो काजेज हैं वो डीप सेट आइज हैं या स्मॉल पेपरल फिशर है और पेशेंट इज एक्सेसिवली स्क्वीजिंग. दिस इज माई लास्ट केस. यहाँ पे दिस वाज अ लेडी हैविंग हिस्ट्री ऑफ ट्रॉमा बाय अ सीजर. शी हैज़ अ कंजक्टिवलाइजेशन ऑफ द कॉर्निया. ये देखिए, इसको हमने 3.5 डायोप्टर का इसका मायोपिया था, एट दी विद द रूल एस्टिग्मेटिज्म था. यहाँ पे सुपीरियरली कंजक्टिवलाइजेशन हुई है. इसकी डॉकिंग बड़ी मुश्किल से हुई. एट 4th अटैम्प्ट मैंने डॉकिंग की है. यहाँ पे देखें तो इसका pupil जो है वो abscised हुआ हुआ है, because it was being operated by me almost 1 month after the trauma by a seizure. तो इसकी डॉकिंग कंजक्टिवलाइजेशन ऑफ द कॉर्निया की वजह से मुश्किल थी. इसको हमने टैकल किया और इसको हमने वो ये अब इसका अबलेटिव प्रोसीजर हो रहा है. यहाँ पे देखें तो स्कार मार्क बना हुआ है. दिस इज अ स्कार मार्क एट 12:30 to 1 o'clock. So you can also do a good refractive surgery in post-traumatic cases with having conjunctivalization if you plan your surgery, and you can always finish with good results. This was my personal observations. For evidence-based practice, you need to have references. When I searched for the references, I found that LASIK flap creation with Zimmer femtosecond laser in 787 conjunctive eyes, they reported 2% complication rate. Another intraoperative flap-related complication in femtolasic surgeries performed with VU Max femtolaser, a 10-year Romanian study, they even reported from mild to moderate type of complications in 5% of their cases. So conclusion is, already published data, evidence-based practice, you can even perform safer procedures and you can continue the surgery. But if you have to halt the surgery, it is not a matter of pride. You can take these cases days or weeks after the day one where you are performing. You can even get very good results after your certain with your experience and with the delayed surgery. Thank you very much.
Thank you, Dr. Saeed Niazi. It was a very nice talk. The next speaker is Dr. Carlo Carlwell. His talk is on trauma after refractive surgery. I think Dr. Carlo is not around. So I'm going to present my talk is on EDOF IOL. Assalamu alaikum everyone. So my talk is on experience of extended depth of focus IOLs, a visual package without the glare. So when we do cataract surgery, we perform phacoemulsification. So what are the unmet needs in effective cataract surgery? Because cataract surgery is nowadays more of refractive. एक ज़माना था पेशेंट हमें कहता था कि मुझे मोती ऑपरेट करवाना है, बट नाउ पेशेंट इज़ मोर टूवर्ड्स के डॉक्टर साहब मेरे पड़ोसी का जब मोती ऑपरेट हुआ था तो ग्लासेस भी हट गए थे, तो मेरे ग्लासेस भी हटाने हैं आपने, तो इट इज़ नाउ मोर ऑफ रिफ्रैक्टिव. सो नाउ वी हैव इनिशियली वी हैड जस्ट वन ऑब्जेक्टिव कि हमें कैटरेक्ट सक्सेसफुली निकालना है. वी हैव टू इम्प्लांट द आईओएल. पेशेंट विल सी हिज मैक्सिमम विजन, विल रीच हिज मैक्सिमम विजन विद और विदाउट द ग्लासेस, बट नाउ इट इज़ ओनली विदाउट द ग्लासेस मोस्ट ऑफ द टाइम. So is it possible to have a full presbyopic correction? Because generally when we do the cataract surgery, we try to reach our target of 20/20 vision or 6/6 vision. But obviously we convince the patient to wear the reading glasses. And there are a lot of multifocal, trifocal, bifocal, intraocular lenses. But now presbyopia, again with the high quality vision, is still a question mark. So in this real world changes and challenges in multifocal and trifocal is you see glare and halos when there are IOLs with the rings into it. You need a good intermediate vision because whenever we implant trifocal IOL, either it's good far vision or near vision, but there is lacking of intermediate vision. Light energy is reduced, so if you compare your one eye with the other eye which is not operated and is little close to 6/6, then you see the difference of light sensitivity and light clarity from the operated eye, and the contrast sensitivity obviously, and the angle kappa, which is more than 3 degrees essential for most of these cases, and brain adaptation. So we welcome a new concept in IOL, which actually started worldwide years ago. We examine a lot of patients in our clinic who get operated outside Pakistan and they come back. We have an EDOF IOL. First time a patient came to me and said, "Doc, I got an EDOF IOL." I was surprised what it was. That was years ago. So it is extended depth of focus, a new intraocular lens technology in presbyopia. It is designed on the base of spherical aberration in the central part and increase the focus depth of the patient to overcome the presbyopia. So it is actually the concept of continuum of the multiple foci. So it reduces the depth of focus, it overcomes the reduced depth of focus, it overcomes the loss of light energy, reduced contrast sensitivity, difficulty in low light conditions, and photopsia. This is how it works. If you look at this upper picture, which is an ordinary IOL, and if you look at where you see there is this part, which is the intermediate part, is blur, and this blur is here as well. And when you go with the extended depth of focus, the patient develops very good, not only the near vision, but the intermediate vision as well. So this is how it works. Aberrations, basically in this type of lenses, aberrations are used to increase the depth of focus. All the phenomena and the game is working on the extended form of the depth of focus, and which works to increase the patient's near vision quality without the night glare. So if you look at this standard multifocal IOL, patient would see a night image like this, and if somebody is having extended depth of focus lens, the night vision will dramatically change. It's really magical most of the time. This is how it is. It is through the simulator. So we have multiple multifocal lenses in the market. There are some which have the full lens with multiple zones. There are some with the multiple zones just in the center. But these type of lenses, they do not have rings. They actually have slight bumping or slight elevations to make the different areas work for the different foci. So these all foci, when they join together and when they make a single point of focus with a very elongated form of focus, it gives you clarity of vision. The optics of the IOL has three distinct areas where different spherical aberrations are applied, unlike the refractive optics, right? So the area 1, if you look at this is the area 1, and it has got positive spherical aberration. The D2 is the area 2, which is negative spherical aberration, and the third one is totally aspherical. So, so it's an innovation in the presbyopia with full presbyopic correction at up to 30 to 35 centimeter, good quality vision in the light conditions, negligible dysphotopsia, and contrast sensitivity is comparable to the monofocal IOL. This is how actually, if you look at this, patient has got far vision, intermediate vision was tested, near was tested, continuity of the vision, contrast sensitivity, and the photopic phenomena. So we get all good ticks in EDOF. This was actually based on data which was filled by the patients, and it was generated like this. The good thing about EDOF is it has got nice neural adaptation. It takes lesser time to get adapted with the brain, and you start seeing better than multifocal or trifocal IOL without the glare. So what you do actually, you perform the subjective and objective refraction of the patient, you do the visual acuities of the monocular, binocular, distant, uncorrected, corrected, intermediate, and then the near vision. Then you check the defocus curve binocularly. Questionnaire is there, which we get the fill from the patient before and after the surgery. So eligible candidates are those who have got active lifestyle, patients who wants independence from the glasses, and those who have activities during the very good near vision, and patient without pre-existing ocular pathologies. This is actually a general, these are the general indications for most of the refractive procedures and most of the trifocal, multifocal, and EDOF IOLs. So outcome is visual acuity usually improves from 1 to 3 months. It is not exactly, it's a magic, but it's not like you do the surgery and then patient comes to you next day and they say, I'm fine, I'm very happy, and I've got a very crispy vision. It slowly, gradually improves. Again, the neural adaptation, brain adaptation takes its time, and it varies from person to person. Patients do develop a good visual acuity for far, intermediate, and near, both at 33 and 40 centimeter. And there is extended depth of focus, which is almost of plus 4.5 of full presbyopic correction. High patient satisfaction is based on the obviously the data form which we collected from the patient, and there is total spectacle independence. Thank you very much. The next talk is by Dr. Shahzad Saeed. a rare case of fulminant endophthalmitis post-TPRK.
Bismillah ar-Rahman ar-Rahim. I'm Dr. Shahzad Saeed. I'm working as a consultant ophthalmologist and vitreoretinal surgeon at Islamabad Eye Center, Islamabad. I'll be presenting a case report, and that was a case of fulminant fungal endophthalmitis following PRK. My unfortunate patient was a 33-year-old male who had no comorbids, and he had a refractive error of minus 2.50 in the right eye and minus 1.50 in the left eye, and he underwent trans-PRK both eyes on 17 June 2023 at a refractive center in one of the northern cities in Pakistan. So everything went well, but according to him, actually he came to me for a second opinion when things went wrong. He told me that the bandage contact lens was removed on 12th post-refractive surgery day. On 2nd of July 2023, he presented with pain, redness, blurring of vision in the right eye to the doctor who had actually done that surgery. On 7th of July 2023, he was given intravitreal injections, which obviously would be antibiotics and probably maybe steroid also. And plus a vitreous tap was taken for histopathology and culture sensitivity. On 10th of July, he presented to me for a second opinion, and this was the condition of his right eye on that day. And we can see hazy cornea with exudates in the anterior chamber with few patches of hemorrhage. In his right eye, he had a subepithelial haze. Vision in the right eye was hand movement, and in the left eye, it was 6/9 partial. This was the ultrasound done on 10th of July, which revealed intense activity in the vitreous in the right eye. The culture sensitivity report, which was taken previously, revealed no growth, but on direct smear and direct gram stain, fungal hyphae were found. So based on that, he was already put on topical fortified antibiotics, topical antifungal, oral antibiotics, and analgesics. So based on this report, we started intrastromal corneal injection voriconazole. We gave a total of 4 injections at intervals, but that did not improve. We also did an anterior chamber wash, as well as we took a tap. After that, the patient lost to follow-up. He came back to me on 7th of September 2023. At that time, he was taking topical antibiotics and topical antifungal in his right eye, but he gave history of getting a tectonic graft from another institute for which he went for a third opinion. So on that day, this was the condition of his right eye. And the vision was PL positive. The left eye, however, showed improvement, and the subepithelial deposits had vanished, and his vision in the left eye was 6/6 unaided. This was the ultrasound done on 7th of September, which again showed infiltration in the vitreous, but it was slightly lesser to what we saw on 10th of July. I did an anterior chamber tap again, but it again did not yield any growth. So the patient, when he presented to me on 10th of July, and when he later on came on 7th of September, had moved from this to this condition, and he was really desperate, seeking some sort of betterment in his visual acuity after the procedure that he initially went for. So why this concerns us? Mostly, refractive surgery is considered a cosmetic procedure. Yes, there are indications where your job nature might require you to undergo removal of glasses. It is a very safe procedure. The safety index is very high. In fact, PRK is considered even more safer than LASIK regarding the complication rate and the infection rate. The keratitis occurring after refractive surgery can be infectious, which includes bacteria, fungi, herpes simplex viruses, and acanthamoeba, or it may be non-infectious with entities like diffuse lamellar keratitis and staphylococcal marginal hypersensitivity. The early onset occurs within 1 week of surgery, and mostly it is by staphylococci or streptococci. The late onset, as was the case in our patient, usually occurs by slow-growing organisms like Mycobacteria, Nocardia, Acanthamoeba, and fungi. The risk factors, these are the risk factors which may be true for any surgery that we do, but we need to preoperatively assess most of them so that the chances of infection peroperatively and postoperatively are least. This is an important slide because clinically we need to find out the suspected cause of that infection, because the culture sensitivity report may take maybe up to a week for the report to come, and in our setups mostly the culture sensitivity comes negative. So this gives us a clue as to what would be the causative agent of that infection. As in our case, there were yellow-white dense infiltrates with irregular margins and endoexudates. But clinically defining and starting the treatment as early as possible is very important. So the possible causes in our case, what could it be? Maybe a prolonged BCL, but then yes, there are patients in which we give BCL for even months and nothing happens. So in this patient, the BCL was removed on the 12th day, which was a bit delayed, but still. He had a little bit of dry eye and eyelid margin disease, but having such a fulminant infection in one eye, the issue was present in both the eyes, is again questionable. Or an infected BCL. We didn't have the BCL when he reported to us on 10th of July. So most probable cause in this patient could have been an infected BCL. So we must keep in mind a few things. Fungal keratitis, although very rare, but we must keep a clinical suspicion, not only in refractive surgery, but in other intraocular surgeries that we perform, because early management, early start of treatment is absolutely important to salvage whatever visual acuity we can provide to that patient. Because as the time passes, the clock is ticking, the results would be very poor. So my question to the audience and to the Cataract Refractive Society would be, we have quite a few refractive centers in Pakistan which are independent. They are not linked to a hospital or a clinic. They are independent refractive units. So what is the sterilization protocols at those refractive units? We go there, we perform the surgery, and we come back. So have we ever checked what the sterilization protocols are being followed? Maybe there are a dozen surgeries or even more being carried out in that center in a day. So this is absolutely important that we need to check even the ducts or the protocols that the staff there is following so that the chances of infection are least. Is there an infection control team? Yes, it's always there in a hospital, maybe in our clinics, yes. But is there an infection control team in centers which are doing independent refractive surgeries? I doubt. Periodic analysis of the OT, the staff, the AC ducts. I remember there have been cases of fungal endophthalmitis in which the spores were coming through the AC ducts. So periodic analysis of whole scenario, including the operation theater, the staff, and the sterilization equipment, we need to do that on regular basis. The quality of disposables. We are charging the patients, we are performing best of the best surgeries, but in the end, we compromise on certain things which can lead to the unfortunate incident that this patient had. We need to be sure that the disposables that we are using, I think we have seen in the last 2-3 months, we have seen quite a lot of happenings in Pakistan in which we have seen people repackaging and re-sterilizing things. So we need to be sure that the disposables, including the BCL, are from a reliable source. Because in the end, doing everything right and compromising on this would lead to what happened in this case. Thank you.
Thank you very much, Dr. Shahzad. It's a really informative talk. And Dr. Shahzad is always a very nice presenter. He always brings something new. The next talk is by Miguel Rishi. I am sure I've pronounced the right name. Why the foreigners are off this? Can we have Dr. Sidra Latif on the stage? Thank you. His talk is on corneal visualization through shine fluid chromography in deciding borderline cases of refractive surgery.
Beneficent, the most merciful, with the permission of the chair. Ladies and gentlemen, today the topic of my presentation is basically the utilization of corneal visualization through sheen flood tomography in deciding the borderline cases of refractive surgery. Whenever we are doing refractive surgery, we are looking at the topography or the anatomy of the cornea. However, at the same time, we usually forget that we have to look at the biomechanical profile of the cornea as well. So Corvus ST for short basically looks at the corneal biomechanics. It is sort of a tonometer, just like an ocular response analyzer, which applies an air puff to the cornea, and by measuring its biomechanics, it gives you a full report. The principle behind using this Corvus is basically corneal hysteresis. Hysteresis is the ability of any organ to first not bend to an external force or take back its shape once that force has been stopped. The similar hysteresis is used in ocular response analyzers. Similar corneal hysteresis principle is used in Corvus. What happens in Corvus basically is that an air puff is applied to the cornea. The air puff first applanates the cornea, then it bends it inwards, and when the air puff is stopped, the cornea will go back to take its shape. This cycle that goes on, the deformation that happens because of the biomechanical properties of the cornea, this basically is the principle behind corneal visualization through sheen flood tomography. And this is very important in calculating in a normal looking cornea whether there are chances of an ectasia susceptibility or whether a patient may develop corneal ectasia once you have performed refractive surgery on them. So refractive screening should not only look at the corneal topography or the tomography, it should also look at the biomechanical profile. So this is the paradigm shift that is occurring now. We want to look at ectasia susceptibility in people by looking at the biomechanical profile, which can be done with the Corvus. So, can you play the video, please? If you look at this pane, once an air puff is applied, the cornea is going to bend inwards, then the cornea is going to take back its shape. By looking at this amplitude of deformation, by looking at the movement of the cornea, the machine is going to measure the corneal biomechanical profile. The assessment report that it's generated is basically the ARV report or the Ambrosio, Roberts, and Vinciguerra report. This is the printout of that report. On the left-hand side of the paper, you have the biomechanical profile. On the right-hand side of the paper, you have the Pentacam assessment. This is basically an extension of the Pentacam program. So first the Pentacam runs, then the biomechanical profile runs. And these are certain distilled indices that we'll discuss. What is a part of this biomechanical profile? We have a stiffness parameter and we have the Ambrosio relational thickness. More is the stiffness parameter, stiffer is the cornea, and this is a safer cornea. More is the Ambrosio relational thickness, stiffer is the cornea, better is the cornea for refractive surgery. So when you look at these two peaks, the patient value should be lying more in the green graph than in the red graph. Similarly, for Ambrosio relational thickness, the patient value should be lying in the green graph rather than in the in the red graph. Whereas integrated radius and deformation amplitude DA ratio, integrated radius means radius of curvature till which the cornea bends inwards. More is the radius, more is the bendability of the cornea, and less safe is the cornea for surgery. Therefore, the value should be lesser. The green side of the curve is on the lower end. Similarly, the deformation amplitude is the maximum amplitude until which the cornea deforms. This also should be lower for it to be a safer cornea. We all know what the Pentacam tomographic assessment is about. We know the axial map, we know the pachymetry map, we know the CTSP profiles, the corneal thickness special profile and percentage thickness increase. We know this is just showing the increase and the thickness of cornea from the center towards the periphery, the upper and lower confidence intervals, and the patient line should be lying within these two confidence intervals. Similarly, for percentage thickness increase, this is nothing but the increase of thickness of cornea from center towards periphery. Similarly, it should be lying within these two reference lines. What are these distilled values, these are important. First of all is the corneal biomechanical and Corvus biomechanical index, which is calculated basically from ambrosio relational thickness and the corneal deformation parameters. This CBI, if the cutoff value is taken to be 0.5, it is almost about 98% sensitive to detect ectasia susceptibility and 100% specific for calculating the ectasia susceptibility. However, many false positives can be entered if we take the value to be 0.5. If we lower the value till 0.25, we have about 90% sensitivity and specificity, which is an acceptable cutoff. Therefore, CBI is kept as 0.25. Similarly, BAD value or Bailey-Ambrosio display D values, we all know it should be within 1.6 to 2.6 or better than 1.6, but not more than 2.6, which would mean outside of the standard deviation values. Most important index which is present in this Corvus report is TBI, which is tomographic biomechanical index. This is basically the best of both worlds. It's combining the tomographic data along with the biomechanical profile and generating a report for us. And its cutoff, if kept at 0.75, the sensitivity and specificity generated by it is the best out of CBI and BAD, which means a 0.75 value of TBI, least chances of having more false positive inside, and a very accurate assessment that a normal looking cornea may have ectasia susceptibility. So, most difficult challenge arises when you see a tomographic report in which one of the cornea has very ectatic features, whereas the other cornea is very normal. We call such a case scenario as VAENT, that is a very asymmetric ectatic eye and a normal tomographic eye. In VAENT eyes, the predictive value of TBI is the best out of BAD and CBI. Therefore, tomographic biomechanical index we can use with very much confidence when we have to decide the borderline cases. I'll just quickly give a few examples. We had a patient who presented to us. This is the manifest refraction of the patient, a very high refractive error, minus 8.25, minus 1.5, minus 8 at minus 1.25 cells, almost equitable in both the eyes. However, when the pentacam of the patient was done, pentacam was normal, quite much normal values. For the right eye, Kmax, however, was 48.2. In left eye, the patient had very high, relatively high Kmax value, and D value was 2.75, which was outside the normal 2.7 value. And especially in the left, 3.13, 8.13 for DA and DP. As a result of which, there was slight ambiguity in this patient whether is a good candidate of refractive surgery or not. Corvus was therefore done. This is the Corvus of the right eye. The tomographic biomechanical assessment, it showed a very good, it was within the safe zone. Corvus of the left eye, similarly, it was in the safe zone. Please play the video. This is the dynamic corneal response that was recorded for the patient. Next, play this. Just look at the movement of the cornea. A very strong movement, no extra oscillations, a good deformation amplitude, and without any extra oscillations, cornea took back its shape. The Corvus of the patient was very good for refractive surgery. Refractive surgery of the patient was proceeded with, and now it's 18 months. At the time that I made this, it was 6 months, but now it's 18 months, and the patient is ectasia-free with no problems. Similarly, another case in which the patient had a very normal number, a minus 5 and minus 7.5, which is a normal spherical number. However, when we looked at the pentacam profile, the right eye had slightly ambiguous values. The BAD was 2.36. And when we looked at the Bailey-Ambrosio display, there was a red hot spot in the center, which meant that when the front elevation compared with best fit sphere and front elevation with enhanced best fit sphere were calculated together, the difference was significant and there was a red hot spot in the front elevation map. The Corvus of this patient was done and the values were yet again within the normal range. And please play the video. Once again, the dynamic corneal response, it was very good. The machine calculated the data to be within the safe zone. TBI was below 0.75, it was about 0.55. So this patient was also proceeded for refractive surgery. Just last example of a patient in which there was BAENT, that is one of the eyes, right eye, it was very normal, and the left eye had severely ectatic parameters. When we looked at the corvus, the right eye corvus was, although the pentacam seemed to be very normal for this patient, the values were good. However, when we looked at the corvus of the patient was 0.72, and in the left eye, which had frank ectatic features, was 1. So this patient was not a candidate of refractive surgery, and this patient was in fact offered corneal cross-linkaging based upon the inherent ectatic properties in the right eye as well. So, to conclude, whenever we have to do refractive surgeries, we are not only looking at the anatomy of the cornea, we should also look at the biomechanical profile or the functionality of the cornea, just to see that if the patient may be a candidate of developing an ectasia in the future. And this will give you a very much confidence into deciding the patients whether they should go ahead with refractive surgery safely or not. Thank you.
Thank you, Dr. Sidra. This was really very, very nice talk, actually. Those who are not performing refractive surgery nowadays, at least they should not get scared of this presentation because this is a little super high. अच्छा जी, मुझे बता दें कि डॉक्टर आयशा फवाद और मुश्ताक खटक साहब हैं यहाँ पर इस वक्त. डॉक्टर आयशा फवाद, because she has got 2 presentations. अगर वो नहीं है तो मुश्ताक साहब आपकी याशी है, आपके पास बहुत टाइम है. आ जाइए. डॉक्टर मुश्ताक खटक, his talk is evaluation of lasers in refractive surgeries, past, present and future.
Bismillahirrahmanirrahim. Good evening, ladies and gentlemen. My name is Dr. Mushtaq Ahmed. I'm working as a professor of retina surgery and general ophthalmologist, FIO Hospital, Peshawar. Today, my presentation is regarding evolution of laser procedure in refractive surgery, past, present, and future. Mainly 2 types of laser are used in laser procedures. Number 1, excimer laser. The excimer laser emit 193 nanometer ultraviolet rays, which precisely ablate microscopic layer of corneal tissue without generating heat. Their main application is in PRK and LASIK, and we also use the excimer laser for PTK purpose, which are usually the scarring occur with PRK, and later on we can do a PTK as well. So the another laser is femtosecond laser. It utilizes ultra short pulses of 1053 nanometer laser rays for precise tissue cutting and disruption. This femtosecond laser is used in many procedures of refractive surgery. Some of them are femtosecond laser. They are used in keratoplasty, ICRS, relax flex, small incision surgery, SLAC, eagle vision, and other different procedures which are used in refractive surgery. So, the excimer laser, which is used for photorefractive keratectomy, this is in late 1987 and early 1990. PRK emerged as the first excimer laser refractive procedure. It involved removing the corneal epithelium before laser ablation, providing an alternative to radial keratotomy. Before the photorefractive keratectomy, people were using radial keratotomy. The pros and cons of photorefractive keratectomy are tissue preservation, versatility, range. It has a very suitable wide range of refractive error, can be corrected with photorefractive keratectomy. No flake related complication. Since there is no flap issue related to flap creation or healing are minimized. It has a long recovery time and discomfort during healing. Sometimes scarring occur in cases of photorefractive keratectomy. The past of excimer laser use was, before photorefractive keratectomy, was radial keratotomy. People were using blade for radial keratotomy. When excimer laser come into the ophthalmic use was that they use first excimer laser is a radial keratotomy purpose. They given vertical cuts is a surgical technique involving radial incision in the cornea to correct myopia. So first excimer laser was used for this purpose, radial keratotomy. But presently the excimer laser is used for photorefractive keratectomy, and photorefractive keratectomy, presently people are using wavefront guided and topography guided procedure, enable surgeon to address not only common refractive error, but also higher order aberration as well. So this is the advancement of photorefractive keratectomy, which is presently using. This is what the topography guided. The pros of topography guided is individualized treatment, provide a high individualized corneal profile, high order aberration correction, and customized visual outcome. While cones can be more expensive than conventional procedure, limited necessity, not everyone may be benefit significantly from the correction of high order aberration. So the another development in photorefractive keratectomy is eye tracking. Eye tracking system has been installed and real-time adjustment improving safety and accuracy. PTK phototherapeutic keratectomy to treat corneal injury or disease including scar, dystrophy, recurrent epithelial erosion. It can be treated with the photorefractive keratectomy. So LASIK and refractive surgery. LASIK and refractive surgery, initially LASIK gained popularity as an alternative to mechanical microkeratome in LASIK procedure. What they were doing, that they make a flap and then the same way as like a photorefractive keratectomy, they give an excimer laser and correct the refractive error. Another picosecond perform first stromal flap procedure. And this was another laser which make a flap and then the photorefractive keratectomy like excimer laser applied. What presently done? Presently, the femto LASIK has gained a very popularity, and this is the very refined method of flap making. It's a type of LASIK in which we use the femtosecond Vasomax laser to make a flap for correction of vision. There is a video, and you can see how we are using, this is what we are doing the LASIK procedure. The LASIK procedure, here you can see that we elevate the flap and then the same excimer laser is applied like in a photorefractive keratectomy. In LASIK, topography guided LASIK. It is an advanced laser correction procedure in which we use topographical map of the eye. So the irregular astigmatism, aberrations, you can correct with the LASIK procedure. Customized LASIK, custom LASIK involve measuring the eye from front to back with a wavefront technology. The information gained in the wavefront map guided the laser in customizing the treatment to your individual visual system. So this is one of the advancement which presently in use, the wavefront technology means custom LASIK. Press-beyond blended vision. What the press-beyond is doing, in this case, the femtosecond laser is again used to convert the cornea into multifocality, like increasing the depth of field for near and distance. So the presbyopic patient can get a benefit from this type of customized LASIK. What the SMILE procedure? In the SMILE femtosecond laser are used to create a lenticule within the cornea, which is then extracted through a small incision. This is how the SMILE is done. There is a small opening made for lenticule, and when the lenticule is removed, the corneal flattening occur and the visual correction has been done. What is the pro? Minimal invasive, and they have a very quick recovery and reduce dry eyes, because as compared to LASIK we gave a cut up to 120 degree, while in case of SMILE, you gave a minimal incision 2 millimeter to 6 millimeter, you can adjust accordingly. They have limited versatility, may not be versatile as LASIK for treating a broad range of refractive error. Learning curve for surgeon may require additional training for SMILE procedure. Suction loss, long duration causes suction losses. Overall, we have done the SMILE procedure in our center at FIO. 6-month data shows the SMILE procedure count was 107, satisfied patient 93%, unsatisfied patient 4%. Complications were in 3% of cases. Most of the complication which occur is suction losses when the cut is applied during SMILE procedure. During this time, the eye movement when occur, the cut is not applied properly, then there is release of lenticule is very difficult. So suction losses occur, treatment decentration occur. So it affects the refractive error. Problem during lenticule extraction, enlargement of incision, cut. Past of a SMILE was relax flex. Initially, they were made like a LASIK. They have made a flap, and then they remove the lenticule manually. And later on, the cut has been reduced up to 2 to 4 millimeter, which is converted into small lenticule extraction through the small incision as compared to the relax flex. Comparison between SMILE and LASIK, silk procedure is same as like a SMILE. It is almost they are the two different name for lenticule extraction. Both have a L, and silk have a L lenticule and SMILE have a L lenticule. So the main difference is that silk procedure is modified form of relax flex, which create a small flap on the cornea to remove the lenticule. While in case of SMILE, it only 2 millimeter to 6 millimeter, depending on the surgeon preference, with no need of flap creation for removal of lenticule. Now the SMILE Pro procedure. This is one of the latest procedure, which is probably very soon we will start at FIO in Peshawar. And this is probably first in Asia that we will start this procedure. Stand for SMILE Personalized Refractive Optimization. Emphasize a more individualized and precise smart robotic assistant approach to vision correction. So this is what the machine is. This is totally robotic and topography guided, and wavefront technology is also used, and artificial intelligence has been used. What the difference between the normal SMILE and SMILE Pro is that a SMILE procedure have the laser spot, cutting spot is 4 millimeter wide, while in case of SMILE Pro, it is 0.5 millimeter. So you will very smoothly, you can release the lenticule and can remove very easily as compared to the normal, which is 4 millimeter distance apart, the spot. So highly versatile, can correct up to -14 diopter of myopia, plus minus 6 diopter astigmatism as well as 6.5 diopter of hyperopia. This is the Smile Pro versatility. And robotic center align, which pick the pupil center by itself, its alignment occur with the pupil. Automatically pick cylindrical axis. So this is another advantage of Smile Pro. Spot size is almost 1 micron. And track distance is 1 micron, 0.5 to 1 micron spot distance. Learning curve, short learning curve due to 2 megahertz because it has a very smooth, sharp cut. So with the spatula, you can very easily remove the lenticule by as compared to the normal smile. So no suction LASIK because the time has been reduced from 33 second to 9 second. So it make a lenticule in just 9 seconds as compared to 33 seconds, which is normally Vasomax 500 made. So a more comprehensive solution for patients seeking optimal vision quality, advanced diagnostic, artificial intelligence, high level of accuracy. So the main conclusion is the evolution from traditional refractive surgery to advanced technique like Smile and now Smile Pro reflect the continuous quest for safer, more precise and visualized vision correction method. So this is the first generation was PRK and then LASIK, and third generation was Smile and now the Smile Pro. Thank you so much for your attention. Any question?
Thank you, Dr. Khatak. Very nice. But I think this presentation should have been on the top of this session because it is the whole history of the refractive surgery, how it is started and where we are going to go. This is the end of the session. If there is any question from the audience? Ji. Dr. Khalik.
Assalamu alaikum. Can we do hyperop cases on this?
Yes, this is in a normal Vasomax 500, which nowadays used in Pakistan. We can only correct the myopia, nearsighted.
Okay.
But in case of Smile Pro, you can correct up to 6.5 diopter of hyperopia. So this have this option for hyperopia, and it is a FDA approved.
Okay. Now we can do with the examiner laser or the same machine?
In case of Smile procedure, there is no need of excimer laser.
Okay.
Only femtosecond laser is used, and femtosecond laser have no extra requirement. Anytime, no gas exchange, nothing. You can do your patient anytime. And this is just you cut the lenticule and remove the lenticule, and you flatten the cornea.
And what about astigmatism? Astigmatism.
Astigmatism, it can correct up to 6 diopter of astigmatism
In
case of Smile Pro. While in case of Smile, you can correct up to 3 diopter of astigmatism, which is FDA approved.
Okay. And in hyperop astigmatism also?
Yes.
Okay.
Obviously.
Thank you.
I spoke to Dr. Qasim Latif Chaudhary because he is running a Smile procedure in Lahore, and he was not very much convinced with the Smile because Smile probably has got a lot of shortcomings because sometimes patients do not get the appropriate outcome that they actually expect. So Smile is still, I'm sure the Smile Pro he is saying that might be better than femto-LASIK or other procedures, but the previous Smile that we were listening about and Peshawar people are doing it, it is not superior to femto-LASIK surgery.
This is a very clear-cut logical. If anyone will want to make a cut up to 120 degree over the cornea and then ablate the cornea. So I think there is a difference between the when you give only 2 millimeter of cut and no ablation. Just you sacrifice a certain amount of corneal tissue from your center and flatten the cornea. So the dry eyes, which usually when you cut with 120 degree of cut, the corneal nerves, which the sensation became decrease of the cornea and dry eyes, and very, very rare or less with the Smile procedure.
Any other question, please, from the audience? So we will The session is over almost because we have now the time is up. If there is no question, so this is the end of the session here and end of the second day of the conference. See you tomorrow, inshallah, or in the evening at the dinner. Allah Hafiz.
Thank you.